know what abnormal looks like. Okay, so this is just a recap of that. So the thing about lymphomas is they are they are tumor cells that originate from the cells in the lymph node, right? So what cells are there in the lymph node? Your lymphoid cells, right? And if you don't, you are expected to know what sort of lymph nodes reside where in the lymph nodes. Do you remember? Not really. Like what is in the follicles, what is outside the follicles. Remember? So what cells are mainly in the follicles? Sorry? Tak dengar. What type of lymphoid cell? B, right? And then outside the follicles is your T cells. Okay. So, just having that basic understanding is good enough for you to be able to identify what type of lymphoma. Okay? And then in a follicle also, if it's an activated follicle, you'll have what is that term called? Starts with a G. Germinal center. Okay? So what happens is, when a cell, so the cell originates, okay, a lymphoid cell originates in the bone marrow, as all your hemopoietic elements do, right? They originate from the bone marrow. And in the bone marrow, lymphoid cells are immature. They are blasts, okay? And then they go through differentiation, right? And then they get ready to be able to function as an adult. But like I said, before it is able to function like a full-fledged adult, right, they have to go to the lymph node first. Okay? So although they are mature cells, as when they leave the bone marrow, they are naive cells. Okay? They are not immature cells, so that's the difference. Cells in the lymph nodes are not immature, they are just naive. You see the difference?
Yeah.
Okay. So when they go into the lymph node, they are considered adult cells, they are mature cells. Okay? But then how do they become unnaive? How do they become mature? How do they become more experienced? So the cells will go through different pathways. But ultimately, if it's a B cell, it goes into the lymph node. If it's a T cell, it goes into the thymus. Right? Have you heard of this before? Okay. So on a higher power, your germinal center will look like this, right? In the middle, your B cells enter the germinal center in order for them to start recognizing different types of antigen. Okay, once they start to recognize a specific type of antigen, they will start to differentiate and they will start to become more experienced, as they say. Okay, and then they will leave the germinal center. Okay. So how does that relate to lymphadenopathy? So lymphadenopathy just basically means enlarged lymph nodes. It doesn't mean lymphoma. It just means that there is lymph nodes that is not quite right. Okay? Pathy usually refers to pathology. So it can be anything. It can be any pathology. It could be reactive. It could be neoplastic. So usually reactive causes would be infection, autoimmune diseases. Okay, and then neoplasia, you can have the secondary neoplasia, your secondary neoplastic mets, or you can have primary lymphoma. Okay, so for primary causes of lymphadenopathy, neoplastic causes is lymphoma, secondary is mets. Okay, so in reactive lymphadenopathy, you can have different types of reactions depending on what the offending agent is. It could be a bacteria, it could be a virus, it could be a parasite, right? So depending on what the offending agent is, the type, the morphology that we see under the microscope will be different. You can have follicular hyperplasia, you can have paracortical lymphoid hyperplasia. Paracortical means the paracortex yang hyperplastic. That is the part that proliferates. In follicular hyperplasia, you see lots and lots of follicles. Okay. In sinus hyperplasia is when you see a lot of histiocytes in the sinuses. Okay, and granulomatous lymphadenitis, where would you see this? What do you think would give rise to a granulomatous lymphadenitis? Infections like fungus, lagi? More likely would be what? Granuloma. Would be granuloma? Kita dah lupa dah granuloma tu apa. Kuat sikit. TB, right? TB gives rise to granuloma, right? Okay, so TB, anything too big for the little inflammatory cells to remove will form granuloma, right? Even in non-infectious causes, but you can get granuloma. So sarcoid, you can get granuloma. So that's a non-infectious reactive lymphadenopathy. Okay. So in granulomatous lymphadenitis, what you see is a lot of different granulomas inside the lymph node. Okay. So example of localized lymphadenopathy, because you can have localized where it drains a specific organ and the infection is localized to that area, or it can be generalized. Okay, it can be all over the body. So generalized tends to be more in systemic disorders or systemic infections or autoimmune diseases, but localized is usually when you have a URTI or you have a sore throat, right? Then you'll have lymph nodes, enlarged lymph nodes in your neck, right? If you have a breast abscess, then you'll have a lymph node in your armpits. If you have a sexually transmitted infection, you'll have lymph nodes in your groins, right? So that's localized. Okay, so because it drains that particular organ, and there's an infection going on in that particular organ, so the lymph node that drains that particular organ will be enlarged. Okay. Okay, so we've discussed briefly reactive causes. Now we'll talk about lymphoma. So now we're just talking about lymphoma specifically and how we hematologists basically categorizes lymphoma. So broadly, there are Hodgkin lymphoma and non-Hodgkin lymphoma. Okay. In non-Hodgkin lymphoma, there are different types. You can get B-cell lymphomas, you can get T-cell lymphomas, you can get NK cell lymphomas. Okay, so whatever lymphoid cell you can think of, they all fall under non-Hodgkin lymphoma. So there's a huge, long list of the different types of non-Hodgkin lymphoma. But you have one type of lymphoma which is a B cell of a B cell origin that is named, that has been given a special category, which is your Hodgkin lymphoma. And the reason why this is because partly historically it was one of the first lymphomas that was discovered, and morphologically it has a very distinct morphology. Okay, it looks very it's a very recognizable morphology. Okay. So when a patient comes and presents to you with enlarged lymph nodes, right? Of course, the first thing you do is you want to rule out reactive causes, because you don't jump and assume that everybody who has a lymph node has a lymphoma. Okay, it's very common for children to come with a URTI and lymph nodes in the neck. It's very common for you to suddenly have just a random lymph node that is enlarged. The difference is usually when you have a reactive lymph node versus a neoplastic lymph node, The reactive lymph node is usually tender. It's painful, tender to touch. Kita pegang when we palpate, when we try to examine the lymph node, it feels quite sore. Okay. Whereas a neoplastic lymph node, a lymphoma or a metastatic lymph node, when you touch it, it's hard, but it's not painful. Okay? So clinically, there are differences. On top of that, you'd ask their clinical symptoms. Ada fever ke? Right? Do you have other symptoms of infection? You want to elicit a history to try and discern whether this patient punya lymph node enlargement is reactive or is it a benign cause. Okay? On top of that, after you've elicited the history, you've done the clinical examination, you do the investigations, right? So the investigations that you do are listed here. No, I wanted to have this slide because I wanted to sort of explain to you the differences. But I can appreciate that at this stage, it's very difficult for you to understand what they all do. Okay, so bear with me while I try to explain it. If you don't understand, just raise your hand. Okay. So of course, full blood count is your mainstay. We always do a full blood count in hematology. A patient comes to the clinic, dia tak cakap apa lagi, kita dah ambil darah dia. Okay, full blood count, hematology, tak boleh dipisahkan lah. So sometimes in lymphomas, they can have a leukemic phase. So what does a leukemic phase mean to you? What did I explain last week when I said leukemia? White cells? Where? In the blood, right? So lymphoma is a tumor in the lymph node. So sepatutnya they stay in the lymph node je lah. Okay? But some lymphomas can have a leukemic phase, which means that they can spill over into the blood. Okay? So if it does spill over, the patient will present with lymphocytosis. Of course, because the lymphoma cells are lymphoid cells, so they can present with lymphocytosis. More often than not, if the patient has bone marrow involvement, okay, so the stage 1 is when it's just stays in the lymph node, right? And then stage 4 is when the cancer cells, the tumor cells, they metastasize to a solid organ, or when it metastasizes to the bone marrow. Okay, so if it metastasizes to the bone marrow, it will affect normal bone marrow function. Okay, so if it affects normal bone marrow function, it can give rise to a cytopenia, right? Because the factory now has warga asing that is non-functioning. So it will reduce the function of the bone marrow, and therefore you can have cytopenia. If the involvement of the tumor is very extensive in the bone marrow, it can even lead to pancytopenia. So we do a full blood count to look at these different possibilities, right? So look at clues as to, is the lymphoma just in the lymph node, or could it be in the bone marrow as well? Okay. Now lymphomas, just like any other tumor, will have a high cell turnover. So anything with a high cell turnover, with a high cell count, will raise your LDH, right? Because LDH is an ubiquitous enzyme in all the cells, so it will be raised. And then, of course, to make a definitive diagnosis, you'd have to do a biopsy of the lymph node. Okay, so you do a lymph node biopsy. You take out the lymph node and you section it and you stain it and you look under the microscope. So what you see is something like this. You see something like this, right? So you besides just looking under the H&E stain, what we can also do is identify the different cells using immunohistochemistry. Have you heard the term immunohistochemistry before?
Yes.
Yes? Do you know what do you know what it is? No? Okay. So immunohistochemistry is basically when we stain the cells, okay, with an antibody. Okay, so that it's an antibody specific. So for example, if I wanted to identify B cells, so B cells will have antigens that are specific to B cells. T cells will have antigens that is specific to T cells. Betul? Do you know any a type of antigen that is specific to B cell? CD? CD20. Somebody says CD20? Okay, so CD20 is a B cell marker. So what we do is we take an antibody that will recognize the CD20, right? And the antibody is tagged with a dye. So immuno means the antibody, histochemistry is the dye. Okay, so chemistry, they use the term chemistry to elicit that it's a chemical reaction lah. Okay, so if the cell is a T cell, it will not be stained by this CD20 lah. Similarly, if it's a T cell, we put a CD3 antibody. If it recognizes the cell, then it will stain. If it doesn't recognize the cell, then it won't stain. So it becomes macam a bendera lah, right? So then you can identify, okay, these are T cell population, this is a B cell population, this is you can even do, I mean, the possibility is limitless. You know, you can stain for anything. Okay. Okay, so once we've done a lymph node biopsy and immunohistochemistry, if we suspect, or well, in any case, we always do a bone marrow aspirate because we want to stage the patient. So it's important that we definitively identify whether the lymphoma has entered the bone marrow or not. Okay, so we always have to do a bone marrow biopsy and a bone marrow aspirate. So like Dr. Nas said last week, aspirate is when you pull out cells, right? When you try to draw out the cells and you smear those on a slide, whereas a biopsy is when you actually cut the tissue out. Okay? So again, you can identify the cells in the bone marrow by doing an immuno test. Okay? So in the aspirate, because it's technically a solution, you can do what is known as a flow cytometry. Is that term new to you? Has it been introduced to you, flow cytometry? You've heard it before?
Yeah.
In whose lecture? Whose lecture? Dr. Vida Kot, right? Because flow cytometry is a investigation, is a test where again we try to find out the lineage of the cells. Okay? So flow cytometry is when instead of putting a dye onto a tissue and seeing it under microscope, what we do is we tag the antibody to the cells in a solution, okay? And this antibody has a fluorescent tag to it, and we flow it under basically macam a little pipe. Okay, at the end of that pipe, ada a fluorescent detector. Okay, so kalau the cell has that antigen, right, it will attach to the antibody, and then when the cell passes through that fluorescent detector, it will light up lah. Okay, so flow cytometry is immuno identification using a solution, whereas immunohistochemistry is identifying cells immunologically under the microscope. Okay? And then on the trephine biopsy, we can do immunohistochemistry. Similarly dengan kita buat tadi dengan the lymph node biopsy. We can also do immunohistochemistry on your trephine biopsy. Okay. And because lymphomas, like all cancers, is molecular in origin. Okay. So we can then proceed to do karyotyping. Do you know what karyotyping is? Tahu tak? Have you seen that before? Where we arrange all your chromosomes. Okay. So if it's a lot of lymphomas, the origin of the lymphoma is translocation, where chromosomes translocate with one another. So if you do the karyotyping, you'll be able to see the translocation. Okay? And then we do molecular studies to look. So if karyotyping looks at chromosome, molecular looks at the mutation at a DNA level. Okay? So it goes even deeper than the chromosomes. We unravel the chromosomes and we arrange the DNA out to find out what exactly is the mutation. Okay? So macam for example, in CML, the chromosomal translocation is 922. Okay? So chromosome 9 and chromosome 22, they translocate and they attach together. So that's the chromosomal abnormality. Okay? It produces a on the karyotype, you'll be able to see an extra long chromosome 9. Okay? But what is that in terms of mutation? The resulting chromosomal translocation gives a what? The BCR-ABL gene. Okay? So that's the molecular. That is at the DNA level. At the DNA level, kita dengan at the chromosome kita just nampak an extended chromosome 9, but at the DNA level we see that it's two genes coupled together. So it's a BCR-ABL gene. And what does this BCR-ABL gene do? It gives rise to a
tyrosine kinase.
Yes, so it gives rise to a tyrosine kinase. It's a fusion protein. Okay? A fusion protein, a BCR-ABL fusion protein. So I want you to see the differences because with this is a very popular exam question. Nanti you all get it confused. What is chromosome? Kita minta chromosome translocation. What is the translocation here? You say BCR-ABL gene. Kita tak boleh bagi markah lah because we don't know whether you truly understand what it means, these terms mean or not. Okay, so chromosome is different, gene is different. Okay. So here, molecularly, we look for the mutation at the genetic level, at the gene level, at the DNA level. And then of course, finally, we also do imaging. We do CT scan, we do PET scan, because there are multiple lymph nodes in your body, widespread, so it is very easy to miss spread of the lymphoma. So the only way to do it is to do PET scan or whole body CT scan. Okay? So now let's go back to the different types of lymphoma. So like I said, Hodgkin lymphoma is special, and in Hodgkin lymphoma you have the classical Hodgkin lymphoma, and then you have the nodular lymphocyte predominant Hodgkin lymphoma. So at your level, I don't expect you to know all the different subtypes, but I do expect you to know that there is a classical and non-classical Hodgkin lymphoma. Okay? And I expect you to know the differences, the differences between Hodgkin lymphoma and the other types of lymphoma. Okay? Tak nak pergi ajar kot. Tak payah ajar lah. So, this little dotted box is just to highlight to you that the majority of lymphomas are B cells. Okay? So, in non-Hodgkin lymphoma, you have the B cell neoplasm, and these are also all B cell lymphomas. Okay? Tak nak pergi ajar lah. Saya balik mana tu? Lah panas. Stand there kot. Macam takut dengan you. I can't step on it. I'm not myself to step on it. Okay, so like I said, Hodgkin lymphoma is a tumor of the B lymphoid origin. Okay, the usual onset in the lymph nodes, and usually the usual onset is the cervical lymph nodes, the neck lymph nodes. Okay, and it tends to happen in younger adults, and in about 50% of cases, you'll find EBV genome, you'll find the EBV DNA in the cancer cells. Okay, so which gives scientists and researchers the impression that EBV has something to do with the pathogenesis. Okay, just again, I want you to try and relate that back with Prof. Ainon's lecture. There are lots of viruses that can cause cancers. Betul? Okay, so here EBV is not an absolute cause, because there are causes of Hodgkin lymphoma where you don't find the EBV genome, but it is a recognized virus entity in the pathogenesis of Hodgkin's lymphoma lah. Okay, so clinically, patient will come with B symptoms, and B symptoms is something that is that is apparent in all different types of lymphoma, not just in Hodgkin lymphoma. Okay, if patient comes with night sweats, with weight loss, fever, okay, and patient comes with enlarged lymph nodes, so all those systemic presentation, we term that as B symptoms. Okay, so even in the other types of lymphoma, we will call it B symptoms. And then I said just now, the lymph node tak sakit. Okay, tapi in Hodgkin lymphoma, sometimes patient can have alcohol-induced pain. So when they drink alcohol, baru dia rasa sakit of the affected lymph nodes. Okay, so again, like I said, the lymph nodes usually affects or starts in the neck or the supraclavicular region, sometimes in the mediastinum, and very, very rarely in the retroperitoneal nodes. Okay, so deep inside your abdomen. Sometimes patient will present with hepatosplenomegaly if the spleen is involved. And instead of lymphocytosis, Hodgkin lymphoma tends to come with lymphocytopenia, meaning that the the lymphocyte count is low. Okay, lymphocytopenia. But if patient comes with lymphocytopenia with anemia, this usually indicates advanced disease. Okay, so I'll show you I'll show you better masa practical next week. So don't forget what I say now. But characteristically, why Hodgkin lymphoma is so distinct from the other types of lymphoma is because instead of having the tumor cells proliferate in abundance, okay, usually kita biasa conventionally when you think of a tumor, you think of that that abnormal cell proliferating dengan banyaknya, right? And that's all you see. And all the normal cells dah ke tepi. Like you don't see the normal cells anymore. It displaces the normal cells, kan? That is the general idea of neoplasia, okay? Okay. But in Hodgkin lymphoma, the tumor cells tu dia scattered. Dia singly distributed. Dia satu kat sini, satu kat sana, satu kat sini. Dia tak form, dia tak cohesive, dia tak form in a tumor mass. Okay? And these cells are very large and very bizarre. They are almost 3 times the size of your normal lymph nodes. Okay, they're big. Sometimes they can be binucleated. Okay, if they are binucleated, they give rise to this. The cells is called Reed-Sternberg cells. Nanti I tunjuk gambar. So Reed-Sternberg cells is pathognomonic. Okay, so what pathognomonic means basically kalau nampak sel tu, itulah tumornya. Okay, so in the background, that's a Reed-Sternberg cell, and that's another cell there, and that's another cell there. But you see other cells, right? In between. And those cells in between are just reactive leukocytes. It consists of other types of lymphocytes, so usually T lymphocytes. It consists of eosinophils, neutrophils. So it has a very inflammatory background. Okay? So sometimes bila kita dapat the lymph node biopsy, the pathologist gets very confused. Ini reactive ke? Ini tumor ke? Kan? So kalau kita nampak this Reed-Sternberg cell, then we are confident that this is a tumor. But it's difficult lah. It's difficult because in a reactive lymph node pun you can get like this because it's a very reactive inflammatory background. Okay? Okay. This is what a Reed-Sternberg looks like. It's binucleated. It has 2 nuclear lobes, and inside the nucleus there's a very large nucleoli. Okay, this is a nucleoli, very large. So it gives rise to that what we describe as an owl eye appearance. It looks like eyes of owls. Nampak tak? Kan mata burung hantu kan besar, and then dia punya mata hitam tu gelap and besar. So we term this owl eye-like or owl eye appearance. Okay? Okay, so macam tadi Dr. Lan cakap, the classical Hodgkin lymphoma ada different subtypes. I don't expect you to know all the different subtypes. This table is just for your information. Kalau I tanya soalan-soalan macam ni pun, I would say which has the best prognosis, macam tu je lah. Like, I don't expect you to know in detail. Okay? Okay. But the classical Hodgkin, the difference between the classical Hodgkin lymphoma cells, the classical Hodgkin lymphomas, and tadi in that table there was a nodular nodular lymphocyte predominant. Okay, the difference is classically kalau kita stain those cells, immunohistochemistry, right? They will be positive for CD30, PAX5. Okay? And they will be negative for CD45 and CD20. But in your nodular lymphocyte predominant tu, dia positive for CD20. Okay? Now, you may be confused because tadi Dr. Helen cakap CD20 is a B cell marker. And then Dr. Helen also said that Hodgkin lymphoma is a B cell lymphoid lymphoma. So how come it's not CD20 positive? Okay, so this is one of the abnormal distinctive features lah. It loses its CD20 expression. But how do we know it's a B lymphoid? Because there are other B markers. Okay, so PAX5 is another B marker. Okay, so they are positive for this B marker, tapi they are negative for CD20. Whereas your non-classical Hodgkin lymphoma, they act more like your normal B cell lymphomas. So morphologically, they may resemble your Hodgkin cells. They may be all these Reed-Sternberg cells or very large cells with prominent nucleolus, and they have that inflammatory background, lots of lymphocytes. Okay, so morphologically, what we see under the microscope is sama dengan your classical, tapi bila kita buat stain, dia tak sama. So that's why it's a separate entity. Okay. So this is the non-classical type. See, again, you have these singly distributed large cells, right? Okay, tapi, and again, you have that inflammatory background. But when we stain it, it's not positive for, it's positive for CD45 and CD20. So it's different from your classical tadi. Okay, so how do we stage? So this is something important. This is something that we like to ask. How we stage lymphomas. So this is staging for Hodgkin's and non-Hodgkin's lymphoma. So the staging is the same. So all lymphomas are pretty much staged the same. So if it's stage 1, it's just a single lymph node or a cluster of lymph nodes within the, if it's stage 1, it's just one lymph node. If it's stage 2, it's same area, same cluster. Stage 3, it may have moved to a different area, but it's on the same side of the diaphragm. So for example, you have lymph nodes in the neck and lymph nodes in the supraclavicular region, or lymph nodes in the neck and lymph nodes in the axilla. It's still above the diaphragm, still on the same side of the diaphragm. Okay, but if it has moved to a different side of the diaphragm, so neck and say groin, then that's stage 3. If it has moved to a extra lymphatic organ, okay, like the lungs, like the skin, like the bone marrow, that's stage 4. And then on top of that, we can further sub-classify whether or not patient has B symptoms. So kalau it's stage 1 but patient has B symptoms, then it's 1B. Okay? Or if it's stage 3, maknanya if they have it on both sides of the diaphragm but patient doesn't have any symptoms, then that's stage 3A. Okay? So why is it important to stage them? Because we can then give the patients their prognosis. We can tell them, okay, don't worry, this is only stage 1 or stage 2. You have a 90% chance of survival. So this prognosis only refers to Hodgkin's, okay? Not all your other lymphomas, just Hodgkin's. But if it's an advanced disease, stage 3, stage 4, then their cure rate, right? Their survival rate comes down because the disease is harder to treat. Okay. So that was your Hodgkin lymphoma. Now we talk about your non-Hodgkin lymphoma. So this table basically tells you the ones that we expect you to know. Okay? So if you buka buku and you see other lymphomas, we don't really expect you to know it because there's too many of them. And the reason why this is here is because these are the more common ones. Okay, so macam diffuse large B cell is the commonest type of lymphoma in Malaysia. Okay, it affects elderly people. and I would say that it takes about 40% of the pie. Okay, so if you were to do an incidence of lymphoma in Malaysia, the LBCL takes the cake. Okay, and then you have your other types of lymphomas, which also are more are commoner than the other lymphomas, but it's still not tak adalah common sangat. Okay, and then in B cells, you can further divide them into low grade and high grade. So low grade means it's very indolent, it's very slow growing, right? Patient often comes to you, it's already advanced sebab masa awal-awal tu dia tak ada symptoms pun, because it's so indolent. It's very at in the early stages it's quite harmless. It grows very slowly. So the tumor bulk pun is not high. Okay, so if you can imagine, LDH pun will not be raised in the initial stages. So by the time they come to you, it's already advanced because dia baru perasan. Bila dah tumor dah spread, baru dia macam start to develop symptoms. So that's a typical low grade presentation. Whereas high grade is lymph node tu mula-mula tak ada. Next week dah 2 cm. The following week dah 4 cm. Tahu-tahu dah besar macam ni. By the time they come to you, it's so big. Okay, so the presentation is very fast, it's very acute, it's very actively proliferating, so it becomes high grade. Okay, so the high grade tumors are the tumors that often kill lah, right? Because they're aggressive. Okay. So again, non-Hodgkin lymphomas are divided into B or T cell origin, and B cell lymphomas are more common. And clinically, they are divided into low grade and high grade tumors. Now, you've heard CLL last week from Dr. Wirda. Okay, so CLL can have a lymphoma counterpart. Okay, so CLL is one of those weird lymphomas or lymphoproliferative disorders where sometimes it presents just as lymphocytosis. Dia tak ada lymph nodes pun. Sometimes they present just as enlarged lymph nodes. Dia tak ada lymphocytosis pun. Sometimes it presents as both. Dia ada lymph nodes and dia ada lymphocytosis. Okay? So if dia ada lymphocytosis, we call it CLL because dia dah leukemic. Dia dah masuk dalam darah. Okay? But if it is only in the lymph node, dia tak langsung masuk darah, then we call it small lymphocytic lymphoma. But essentially, they are of the same cell origin. The origin of the cell is sama. Okay? Maknanya dia behavior dia sama lah. The cells it will have the same phenotype. The pattern of the disease is the same, slow growing, indolent. Okay? Cuma the terminology is different. If it's in the lymph node, it's a lymphoma, and we call it small lymphocytic lymphoma. If it has a leukemic phase, if it's in the blood, immediately, whether or not patient has a lymph node or not, kita panggil CLL. Okay? Tu je beza dia. So the features overlap with your CLL. So nanti kalau you tengah study, kira 2 in 1 lah. You belajar pasal small lymphocytic lymphoma, you're also studying about CLL. So it's a disease of the elderly, usually adults of 60 years and above, and it's more common in the Western world. Okay, so it's less common here, but in America, in Europe, it's a very common disease. So I'm not going to delve too much into CLL because I'm sure Prof. Wirda has explained it extensively. But just to highlight that SLL is a lymphadenopathy lah, and dia tak ada cytopenia, dia tak ada B cell infiltration in the bone marrow. Okay. So morphologically, you've seen this. I'm sure Prof. Rida has shown, and then nanti bila practical, I will show it to you again. But if it's in the bone marrow, this is what it looks like. Okay, so this is the parts of the bone marrow that's not affected, right? So you see the normal bone marrow morphology, you see hemopoietic elements together with fat spaces, okay? But then you see these large aggregates of bluish looking cells. So these are your lymphoma infiltration, okay? So this is typical of, this is what lymphoma looks like, any type of lymphoma. When they infiltrate the marrow, this is what it looks like. Okay, okay, when I say any type of lymphoma, I'm referring to the low-grade ones lah. The high-grade ones will obliterate. Okay, it will be so aggressive, it will affect the whole marrow. Okay, but your low-grade lymphoma tends to be like this. It forms little nodules macam ni inside your normal bone marrow. Okay. So this is also again something that Dr. Rida should have explained, staging and prognosis for CLL. Okay, so this is a staging and prognosis for CLL, not small lymphocytic lymphoma. Dia ada explain kan? Ada tak? Binary and Rye staging? Tak ada. Tak ada. Kalau tak ada, kita abaikan. Okay, but in lymphomas, in CLL, there are other prognostic factors. Okay, so if you have, on top of everything else, if you have mutations, macam isolated deletion 13q, right? It's a good prognosis. Okay, or if your immunoglobulin heavy chain is mutated, it's a good prognosis. If it's unmutated, it's a poor prognosis. Okay, so these are just prognostic factors. I should have removed this actually. Okay, so another type of lymphoma is called mantle cell lymphoma, and again it's a B-cell neoplasm where the cells are mature, okay, and so they look like just mature lymphocytes that have proliferated extensively. But although it's a mature lymphoma, so morphologically they can look like CLL, or small lymphocytic lymphoma, but they tend to be a little bit more aggressive than your other low-grade lymphomas. Okay. Okay, and then this mantle cell lymphoma pun can have a leukemic phase. Okay, so it can overspill into your blood, and it will look like this. Okay, so you have lymphocytes in the peripheral blood or the blood smear, and they look like mature lymphocytes, so their chromatin is very clumped, it's very dense, and they have very little cytoplasm, but sometimes they can have this cleaved appearance, like the nucleus is cleaved. So as the name suggests, mantle cell lymphomas originates from the mantle zone. Okay, so what you see is tadi, if you remember, there's a germinal center and then there's a small thin layer of mantle zone, right? But in mantle cell lymphoma, because the cells originate from the mantle zone, so the mantle zone will become thicker and your germinal center will become smaller. So it displaces the normal elements. It displaces the germinal center. It will cause the paracortical area to be very thin, okay, because your mantle zone has expanded. Okay, and the most prominent feature of mantle cell lymphoma is that it involves the translocation 1114. Okay, and it leads to a fusion of cyclin D1, okay, with your IgH gene. IgH is immunoglobulin heavy chain gene. Okay, so a lot of the lymphomas, the translocation originates with involves the IgH gene. So you will see 14 in a lot of different lymphomas. And I show you. So it's not just in mantle cell, but mantle cell it involves 11, which is the cyclin D1, which houses the cyclin D1 gene, and 14, which houses the IgH gene. Okay. Okay. Follicular lymphoma, as the name would suggest, arises from the follicles. Okay. Specifically, it arises from the germinal center. So, morphologically, it will look like the germinal center is besar and there's nothing else. Okay, so what happens is it forms many different types of follicles, of all shapes and sizes. So you will see a follicular hyperplasia. Okay. Again, okay. So these are the follicles, lah. Okay, you see lots of follicles, and I don't know if you remember this, but tadi germinal center looked a bit lighter than the rest of the cells, kan? The rest of the areas. So that's why this one also looks lighter lah. Dia macam dah tak ada dah that mental zone area yang darker. It doesn't have that anymore. It just has lots of different follicles with enlarged germinal centers. Okay, so here the translocation is 14, which is the IgH, and 18. Okay, 14, 18. So 18 houses the BCL2 gene. Do you remember what the BCL2 does? So it has something to do with your cell cycle. Okay. It has something to do with apoptosis. Yeah, remember? Okay, tak apa. Nanti you go back and you study, then it will be lagi you ingat. Okay. So here are the just a summary of what I've explained just now. Molecularly, CLL doesn't have a pathognomonic gene rearrangement, but it can have other genetic aberrations. Tapi for mantle cell lymphoma, 1114 is memang the translocation, and follicular lymphoma is 1418. Okay, so then the immunophenotype is different. So that's why I said the other way we distinguish the different types of lymphomas, not only morphologically, but we look at the different phenotypes. Okay, so I don't know if you remember this, but CD5 is a T cell marker. Do you know that? CD5 is a T cell marker, but it's aberrantly expressed in CLL. So it shouldn't, but because they are cancer cells, suddenly they express CD5. Sama juga dengan mantle cell. So this also expresses CD5. Okay. And then they express B cell markers, CD20, 19, 79 alpha. These are B cell markers. Similarly here, 19, 20, 79 alpha. They are B cell markers. And down here as well, they are B cell markers. So that's how we know they are B cell origin. Tapi in follicular lymphoma, dia CD5 negative. So it doesn't express that CD5. But what it does express is germinal center markers. So what are the germinal center markers? CD10 and BCL6, but BCL6 tak ada kat sini. And of course, because it involves the translocation 14-18 rearrangement, which involves the BCL2 gene, your BCL2 will be overexpressed. So you will also have it will also be positive for BCL2. So that's how we differentiate these different lymphomas lah. Okay. So now we go on to the high-grade lymphomas. The high-grade lymphoma is lecture dengan siapa? Betul itu. Okay. DLBCL, like I said, is diffuse proliferation of aggressive type of B lymphoid cells. They are derived from post-germinal center. Okay, cells tu dah keluar daripada germinal center, dia dah jadi mature. They're about to go and live their life as mature lymphoid cells, tapi they become cancerous. Okay, so this is the most common type of lymphoma, and it's very aggressive. Okay, so this you can read. Then the other type of aggressive lymphoma is Burkitt lymphoma. Okay, so Burkitt lymphoma also originates from the germinal center. Similarly dengan follicular lymphoma tadi, tapi beza dia dengan follicular lymphoma is this is very aggressive, and it tends to again occur in younger adults. Macam Hodgkin's lymphoma, it tends to occur in younger adults. Okay. Burkitt lymphoma has different variants. You have the endemic type, where it happens in sub-Saharan Africa. Okay, and this one also has also affects children more often than not. And then the type that we get outside of sub-Saharan Africa is called the sporadic Burkitt lymphoma. And then on top of that, patients with immunodeficiencies like HIV can also get immunodeficiency associated Burkitt lymphoma. Okay, so morphologically, they look a little bit more plastic. Okay, they look a little bit more immature. They have very open chromatin pattern. Okay, and then they have vacuoles. Okay. So the translocation involved is translocation 814. Okay, so just to recap, Burkitt lymphoma is 814, renal cell lymphoma is 1114, and follicular lymphoma is 1418. CLL or small lymphocytic lymphoma tak ada translocation. DLBCL pun tak ada translocation. Tak ada specific translocation. Okay. So this is my last slide. So this is T-cell lymphoma. The take-home message for this one is that adult T-cell leukemia lymphoma is associated with HTLV1. Okay, so this again is a virus that memang is associated with this lymphoma. Okay, so it is the reason for this lymphoma to occur. I don't have time for questions because Dr. Wida's lecture. Tapi petang ni is practical and I'll be conducting it, so you can ask me then. Okay? Okay.